How's your Friday going so far? Hopefully great. We're going to just take a few minutes for people to pop in. I don't know where you are, but it is storming outside, so I am grateful to be inside, not driving out on the roads today.
We need the rain here. I feel like it hasn't rained in like a month.
I think it's supposed to be storming this weekend too. Hopefully I'll send it your way. So, yep, welcome everyone, those who have just joined us. We're just going to spend a couple more minutes just waiting for the people to enter so that we can all be on the same page. Welcome, welcome. For those who are joining us, we're about to get started in just a minute. Okay, let's just rock and roll. Those who join us can chime in when we get to it. So, first of all, just want to thank you all for coming. I am super excited. This is our first national webinar where we are going to be committing to educating you all and our community on neurotrauma. There's so many angles of neurotrauma that is unknown, and I'm grateful that we have someone like Dr. Jeremy Hertza join us today to speak on the topic. Our goal is to do this the first Friday of every month ongoing, and for it to be something that you can refer to and grow from, whether you're on the medical side or the legal side. Today's focus is on the legal side, but I think that you're going to learn a lot even if you are not on the law side about neurotrauma and how it can shape the way that you build your cases and share it with your attorneys. So with that, just want to say good afternoon, everyone, and welcome to our All Things Neuro seminar or webinar. I'm thrilled to have you join us, especially for those who work on the front lines of personal injury law and healthcare. We know how demanding your work is, and our goal today is to equip you with practical tools and insights that will help you serve your clients and patients even better, especially when it comes to identifying and supporting those with traumatic brain injuries. Just a little bit about who we are so that you know why we're doing this and how we can help and serve you. You may not know us yet, but All Things Neuro is a brain health clinic that specializes in supporting individuals with post-concussive symptoms and complex neurological complaints, especially those that arise from car accidents and other personal injury cases. We are able to help those who are not on that side, which we can talk about later. But we provide evidence-based care through a telehealth model as well as in person, depending on where you are in the country, making high quality neuro care more accessible for people when and where they need it the most. So our goal is to be a comprehensive solution, whether it's the evaluation side, the testing side, or the treatment. We have solutions from all angles. At All Things Neuro, we offer a suite of services tailored to help clients recover from traumatic brain injuries, especially from screening and symptom checklists to full neuropsychological evaluations and guided telehealth rehabilitations. So we partner up with different referral sources that we contract and work together with, from personal injury attorneys, chiropractors, and medical providers who want a trusted partner to evaluate and treat the invisible injuries that often go undetected. We're here to help you get the answers for your clients and support your cases with documentation and ultimately to improve patient outcomes. We also offer some post-care specialization services on the litigation side. We can help with impairment ratings, medical evaluations, life care plans, and so our goal is to be a one-stop shop solution for you. Oh, that'll be my next one. But for today's session, we're going to be focusing on litigating the invisible injury and talking about how TBIs can help in neurotrauma. So our session today is going to be with Dr. Jeremy Hertza. So I want to definitely dive in and make him the center focus here, because that's why you're all here in the first place, and introduce you to him. So be patient, because he has a long credentialed record, and I want you to understand who you get to speak with today. So Dr. Jeremy Hertza received a Doctor of Psychology degree with a specialization in neuropsychology from the American School of Professional Psychology in Washington, D.C. He's board certified by the American Board of Neuropsychology and is a fellow of the National Academy of Neuropsychology and American College of Professional Neuropsychology, the latter of which he serves on the board as director, as member at large, and chairman of distance learning. Dr. Hertza has been a member of the psychiatry and neurology departments in the Medical College of Georgia for over 15 years, currently an associate professor, while also serving as the medical director for Neuropsych Centers of Georgia, CEO of Neurobehavioral Associates, and chief medical officer of Integrated Psych Solutions. As medical director for NPC, Dr. Hertza helps to ensure consistent, high-quality, evidence-based care for forensic and workers' compensation patients, working with staff to ensure that they are well-trained in managing depositions and courtroom appearances. As part of IPS, Dr. Hertza manages a comprehensive team of psychiatry, neuropsychology, psychology, social work, and therapy, active in the Southeast, providing mental health to burn centers, trauma centers, rehabilitation hospitals, emergency rooms, and long-term acute care facilities. Widely, widely published and active in national organizations, Dr. Hertza specializes in neuropsychology of children and adults with particular interest in trauma, TBI, across the lifespan, and forensics. Interest in TBI has led to significant medical legal work, particularly on the civil and workers' compensation side. Dr. Hertza was chosen as one of the neuropsychologists selected nationally to work with the children of the Flint water crisis, assessing the impact of lead on brain function and helping with associated trauma and PTSD. Most recently, Dr. Hertza accepted the position as internal neuropsychologist for Davis Life and Health, where he advises the insurance company on how to translate medical records and test data into meaningful, functional, and occupational restrictions. I don't know how many times I said the word psychology, but I said it a lot. And it's amazing. There's a lot of misinformation about the mental health of like psychiatry, neuropsychology, and psychology. And hopefully Dr. Hertz will be able to explain that to you so that you come back with a better understanding about what he does and how this is going to help your cases. So with that ado, I'm going to stop sharing my screen and turn it over to Dr. Hertza.
Well, hello, everybody. All right, let me share my screen and we'll get started. All right. So today we're going to talk about, well, lots of things, but we're going to talk about neuropsychology as it relates to forensic settings. And as we do that, we will also discuss traumatic brain injury, mild traumatic brain injury, neurochemical response to stress, PTSD, intervention. So while this may be framed up as talking about neuropsychology, as previously mentioned, we're really discussing neurotrauma and all the different ways that we can help assess things. So as a brief overview, we'll discuss what is neuropsychology, why in the world do you need it, what is the process, what does a report look like, and we're going to have some very specific case examples about how neuropsychology can tease things apart. So here's some introductions, and these are based off of real cases, some of which on the call may have actually been involved in. We'll talk about Betty. Betty was hit by a bus while parked in traffic. She had whiplash, but she had passed ADHD. Her Glasgow Coma scale was 13 to 15, which is in the normal range. And she's a nurse practitioner, fully back to work, and she's seeing patients. We'll also talk about Cindy. Now, she fell on broken concrete outside a restaurant. She lost consciousness, but there was no skull fracture. She was really emotional after. There's a history of sexual abuse and bipolar disorder. Three will be Sean. Now, Sean was shot in the head as a 3-year-old, and he suffered a stroke and brain hemorrhage after a work fall from scaffolding. The location of the stroke was the exact location that he got shot at age 3, and he's Spanish speaking. He does not speak English. John went for a nose job due to a deviated septum and due to medical malpractice, pierced the membrane with cerebral spinal fluid leak. Frank, in grade school in Flint, Michigan, the pipes were leaching chemicals. And all of a sudden, he found that at age 8, he struggles to read. He's impulsive. He's socially awkward. Peter, a police officer at a traffic stop next to a car, it took off, it caught on his arm, and he was dragged. He was just dragged. Now he's aggressive, angry, disagreeable. We'll talk about Bob, a boxer who had a car accident who's now having worsening thinking, but he has a Parkinson's tremor. Is this CTE? Is it a brain injury? So all these represent a huge variety of cases, and I think they really highlight the complexities that we all run into. Our patients, our clients come to us with their histories, and there are pieces of things that don't always add up or that can be difficult. As we discuss this, I'll talk about a couple different cases that I'm involved in. One was just yesterday. I was in a jury trial and I was asked, Dr. Hertza, did you consider previous medical facts? Did you consider their history? And my response was, I did consider the car accident they got at age 17. I did consider the learning problems that were rectified with speech language therapy by age 6. I did consider the COVID that occurred in 2019, but there was no evidence of the cellular inflammation and anoxia that's tied to cognitive deficits. So you have to own all the things that go into this and try to understand what's going on. Um, so there's lots of things that can happen to people, right? They can have car accidents, they can have falls, their head can impact from a variety of ways. I have a case I'm working on now where somebody was at Target and they were out in like the area where they have the garden and things like that, and somebody was pushing a giant cart that all the way up top was full of like furniture and things, and the whole cart fell on top of him because the person couldn't see around it. Um, Pain, surgery can all impact cognition. So the bottom line is something happened to the person. They get him to you as the lawyer, they get him to you as the chiropractor, or get him to you as the clinician. And we need to understand what that is and how it affected them. So I want to talk a little bit about what happens to somebody in like, we'll use a car accident as an example, or even the guy who everything fell on his head, right? And ultimately he had a broken rib and a bunch of other issues tied to it. But immediately after an accident, there's lots of things happening in the brain. On one hand, particularly in regards to concussion, there's a neurochemical cascade. Why? Well, the brain's freaking out and it's trying to preserve our life. So what does that mean? It means it needs to take oxygen and pump it to our muscles as quickly as it can in order to protect us. Similarly, think about it this way. If you're sitting there and you're cooking dinner and you all of a sudden put your hand on the stove, you don't sit there and go, wow, that hurts. Maybe I should move it. Yep, definitely feeling it. No, You just move it. So how does that happen where you have no thought but immediate action? Well, because the brain is coordinating that effort in order to have that immediate reaction. So when there's trauma, when the brain's shaken, when it hits something, it has this reaction. And within that is a full neurochemical cascade. Now, what's important is that even people with normal Glasgow coma scales, 13 to 15, still undergo that neurochemical cascade. So a normal Glasgow coma scale doesn't mean nothing happened. Now, of course, it means that the patient, the client, didn't display the symptoms roughly a half hour after injury, consistent with anything more than moderate symptoms, but regardless. So the point is that we need to take our time to understand what's happening. So the first thing that goes on is a depolarization. Then there's a release of excitatory neurotransmitters, most specifically glutamate, the ion shift, which changes metabolism, alters blood flow, and ultimately can impair axonal function. So this is a really complicated picture that's pretty hard to see, but that's essentially exactly how I want you to feel is, wow, this is complicated and hard to see, right? That these are chemical reactions that are occurring. So this shows the roughly 7 to 9, 7 to 10 days of the normal pattern of chemical response and then ultimate recovery. Now, 95% of people fully recover after concussion. Most people are going to recover within this first 10 days or roughly the first month to 3 months. Now, the research is a little different on younger people, particularly like athletes. They seem to recover at an even greater rate. So ultimately, you could see there the glutamate. You could see as it spikes, you could see the changes in potassium, calcium. But what I really want you to pay attention to is the line below 100, and that's CBF, cerebral blood flow. So you could see that there's a decrease of blood flow, a decrease of oxygenation through the brain within that period. So this is partially why we talk about second impact syndrome, where you have two injuries in roughly the same period of time, particularly during this first 10 days, because the chemistry still hasn't gotten right. Okay, so you got in an accident, all this is happening. Your chemistry is changing, your brain's freaking out, the blood flow is changing. At the same time, you're having a stress response. And we know that. I mean, any of you that have been in a car accident, me too, you have a stress response. Now, one thing I want you to understand too about all these things, the stress response and then also the neurochemical cascade, is each one of these things is associated with symptoms. It just makes sense when you think about it. The ion flux tends to be associated with headache, latent sound sensitivity, the energy crisis, vulnerability to second injury over that period that we just talked about, axonal injury, impaired neurotransmission, and ultimately this could lead to cell death. So like I said, the brain's freaking out. It's clearly a very unhappy brain there on the slide. And our whole body responds to stress. So this chart here shows um, just some general autonomic, sympathetic, nervous sympathetic responses. And you can see it's affecting all the organs, your pupils, all different aspects of your body. Now, there's different structures of the brain and different pathways that are involved in that stress response. Really, the best way to kind of say this in the most, I think, understandable way is our stress response involves a crossroads of different things because the brain has to coordinate all these different things at once to respond. And the main area of that is the hypothalamic pituitary adrenal axis. So you have your hypothalamus, you have your pituitary gland, and all these things are connected in a way that helps us respond. And in part of that is a structure called the amygdala. The amygdala controls kind of, should we have a stress response? Should we not? Should we activate our chemicals? It also has to do with memory of negativity, fear, anger, right? Feeling threats to ourselves. If you've ever talked to somebody with PTSD, spend some time with them, and they describe their nightmares, they describe the images that they experience, they're different. I mean, they can't remember what they ate for lunch 2 days ago, but they can tell you this image in incredible, vivid detail. How? Why? Why is that memory different than others? Because it's a different part of the brain. The amygdala is handling that stress type memory, and the hippocampus and the limbic system, which handles homeostasis, olfactory, memory, and emotion. Um, that's more related to like facts, experiences. So the point is this amygdala, in conjunction with all these different pathways, can short circuit. And it could short circuit to the point where it cannot be shut off. And as part of that stress response, different chemicals are released, right? Cortisol being one. Now, cortisol's naturally occurring. It's not a bad thing just to start things off. It's a stress hormone. And in fact, in low levels, it helps us. I mean, in school, they always say a little bit of stress is good, a little bit of anxiety is good. And there's truth to that. It actually leads to heightened memory, quick bursts of memory in particular. Now, what happens though if you have this chronic over time? You had someone that's in a car accident, they're really stressed, they're experiencing this trauma. Now, 3 months, 6 months, a year later, they're still having nightmares, they're still having these type of responses. And with PTSD, you have chronic levels of cortisol because it can't shut itself off, which is what we talked about. And chronic levels of cortisol lead to impaired cognition. Your thyroid is suppressed, your blood sugar has imbalances, your bone density changes, lowered immunity, increased abdominal fat, right? I always make the joke when I giving this lecture to lawyers, clearly some of you have been stressed, right? As I look around the room, because chronic stress does lead to these things. So for somebody that has PTSD, neurologically, biologically, it changes them. And the body responds to stress, as we've talked about, in a variety of ways. And this slide highlights some of the chemicals involved: DHEA, GABA, and each one of these is associated with different pathways. Now here, just like we talked about with concussion, over 9 days, the brain tries to reset itself, right? It's no difference with regards to stress. You have a response, the body reacts to protect itself. You have a feedback loop based on cortisol levels in the hypothalamus that resets us. But again, sometimes, particularly with regards to chronicity, it doesn't reset. Okay, so now we're going to talk about neuropsychology. So what's the framework that we just laid out there? That people's injuries are complex, that they bring lots of different factors to the table, their own experiences, different things that affect thinking, right? We've also discussed that when people undergo trauma, including a mild traumatic brain injury concussion, there are neurochemical brain changes, brain reactions that occur. So to understand that and understand how that affects people, how it impacts their function, their lives, their employability, this is where neuropsychology steps in. Now, a neuropsychologist is a specialized field that combines neurology, psychiatry, and psychology. Now, we're not neurologists, we're not psychiatrists or traditional psychologists. Generally, a PhD or PsyD, a doctorate in psychology with the specialization in neuropsychology requiring a 2-year fellowship. There are several boards out there for certification, but the primary two are ABPP and ABN. And roughly in psychology, that's about 5% of providers. So there's just not a lot of psychologists that are boarded, but there are more boarded neuropsychologists than other specialties within the field. Now, a psychologist that's a neuropsychologist has additional training in neuropathology, neuroanatomy, and we are focused on evaluating the relationships between behaviors and brain function. It is an applied science that has statistics, that is data to help us understand what's going on. So I'm asked often, so Dr. Hertza, you're not a physician. Nope, I'm not. It's true. Can I prescribe? Yeah, in some states. I think it's 7 federally, but there's additional training that needs to go into that. But what I am is a doctor who only specializes in the brain and how it works, not distracted by other things. And where a neurologist may spend 15 minutes, maybe 60 minutes with the patient, a psychiatrist 30 minutes, maybe an hour or two, we're spending like 5, 6, 7, 8 hours and then writing complex reports. Yesterday in court, Dr. Hertza, can you tell me how many times you saw this patient? 4. Saw this patient 4 times. Okay. So you were treating them for a year and a half. You only saw them 4 times. Correct. Okay. And you think you could provide an opinion after seeing them 4 times? He said, well, we did spend 20 hours with the patient over those 4 times. What other provider spent 20 hours with the patient? There's no response to that. There was nothing, no further questions. So we really take our time, and now that's important because when you try to take data and translate that to functional, occupational limitations and restrictions, You need to spend a lot of time with someone. If you spend an hour with somebody, half hour with somebody, how do you know how they're going to do when they're at work under lots of stress, 8 hours at a time? You really have to challenge them and be with them. And there's standardized procedures that are used in neuropsychology, and the data is compared against people like our patients. One of the things that's important, and we'll talk about it as we go, is this notion of premorbid status. What does that mean? That means understanding who somebody was before the injury and comparing them to that so you could really understand changes, right? The nurse practitioner we talked about earlier, and we'll cycle back to that as well, right? So if she's coming out at lower average, lower end of average, but her intelligence before was top 5%, do you want her working on you? It's a problem. So we really provide a very detailed cognitive examination. Now, neuropsychology is concerned with the relationship between the brain, emotions, cognitions, and really want to be very diagnostically accurate. One of the things that All Things Neuro does a great job of is pulling all these data points together and to understand how that supports a particular case. So you can have vision, right? You can look at how the visual system and vestibular system responds. You could look at what does the neuropsych data look like. You can do different types of imaging, right, to help understand what you're seeing. And we're pulling all that together. Now, psychiatry is generally interested in medical management of psychiatry, of meds and mental health issues. So why consider neuropsychology? It can answer the question, what in my case is real? So I get cases often where I'll be sent 1,000 pages of records, and the lawyer asks me, Dr. Hertza, can you just tell me what in the world is going on here? Help me understand, like, where do I hang my hat? What's actually happening? Is there a concussion? Is this mood? Is it medication abuse? Like, what in the world is going on, right? We also test for malingering and exaggeration. There's no other field that does that. Not only do it once, statistics show you need to do it at least 3 times, and we do 5. And you can't do it at just one point in the assessment, because what if, they start off aching and then eventually they don't? Or what if as they get tired, they start to not try? And you can't do it in just one domain. So you can't look at just memory or just attention or just mood. You have to look at all these different things. And we do that so we have confidence in what we're saying that could stand up in court. Um, so we can tell you the extent and nature of cognitive impairment. Think about it this way. Let's say you did all this testing, and there's a lot of new technology out there to try to understand concussions and support concussion. And you did this testing, and all these things say, yep, they had one. Okay, great. How severe is it? What data supports that? What type of accommodations do they need at work? How does their mild traumatic brain injury impact their employability, their future, their day-to-day life? How are you supporting that? Just by what they're telling you? By a collateral? We have data that supports this, and we could translate that data into functional, occupational restrictions, and ultimately limitations, which in turn lead to what type of care do they need long-term, which builds the care plan, right? Which then helps support our patients, our clients in their cases. So we can detect symptom exaggeration. We could turn relatively abstract symptoms, brain fog. What's brain fog? I think slow. Okay, what is that really? We could turn that into data. And when you do a neuropsych assessment, you're not just getting the neuro piece, you're also getting all the psych assessment, all the assessments of emotions. Why? Because it comes from the brain. The brain's weird. Treatment of the brain's weird. When you go to a cardiologist, you don't usually go to this one guy who does one valve and this guy who does this valve. You have a cardiologist. But when it comes to the brain, you have neurology who's dealing with systems and meds. You have psychiatry who's dealing with, okay, mental health, even though it's the same brain. But it's not blended, it's not integrated. That's what neuropsychology is. So if you add a neuropsychologist to your case, it gives you the tools to help a judge, help a jury understand the severity of symptoms and what that means. In the case I had yesterday, this is a nurse, and the data supported that there's no way she can do patient care again. No way. Now, could she work maybe doing some type of utilization review for an insurance? Yeah. But can she work to her previous capacity? Absolutely not. And you won't get that without the data to support that. It turns symptoms into impairments and helps create the story of what's happened. Now, one of the things that we do at Neuropsych Centers and all things neuro as well is we can screen your case. So that way we can tell you, hey, this is where you think you need to go, or this is what's next. I'll give you an example with pain. You can have a patient that has lots of pain. Maybe there's no brain damage, but pain impacts thinking, pain impacts emotion, pain impacts function. And each of those require separate interventions that ultimately are written into care plans. These are layers to cases that understand what's happening with our patients and how to support them. So, okay, I get that testing, thinking emotions is important. We can screen my clients, we can evaluate them, we can guide treatment. Why do we need a neuropsychologist to do it? Lots of providers say they do testing. I mean, you'll have chiropractors that screen, neurologists that screen, primary care that cleans. So what do I need a neuropsychologist for? Listen, they could screen. That's fine. But a neuropsychologist is the only provider that's trained in neurology, psychology, tests and measures with board certifications to back it up. They're the experts in this space. Our methods are defensible. So, okay, fine. Do I really need a full neuropsych assessment? Can I just like screen it? I got some lower limit cases. I tend to be a more volume type practice. Or can I just send you some records and you guys just let me know what you think? We're well positioned to do all these things. We could screen clients. We could help determine, do you need a more expensive tier of care? Do I need a neurologist? Do I need a psychiatrist? Right? Um, what's needed next? Help me understand how to move forward. So let's go back, right? Let's talk about our patients. Betty with the bus. How severe are her impairments? She's back at work, but she has ADHD. So how much of her deficits are due to ADHD and how much is due to the impact of this bus, right? And again, if you remember, she's out there working and she's doing her thing. So you have to help understand that. I will say on the case with with Betty, I think the case and the lawyer was awarded $6-7 million. Why? Because even though she can work, it's nothing like it used to be. She works all night. She's exhausted all the time. She has no balance in her life. And if you look at the records prior to injury, you could see stable ADHD with her functioning at a very high level in a very busy clinic. Cindy with the fall. What's actually due to the fall? What's due to her previous emotional instability? How do you figure that out? What about Sean? He was shot in the head at age 3. It's the exact part of the brain that has to do with language and expressing himself and sounding out words. And now he has a brain bleed in that exact same spot. How do you deal with that? And I mean, we gave the test in Spanish, but how does that factor into all this? Now, John, that's where ultimately during that nose job, everything was punctured and he had cerebral spinal fluid just, it poured out of his nose, poured out of his ears. Uh, John's really a terrible case. He's at the point now, because of the change in cerebral pressure, that if he lies down to sleep, he has excruciating pain for about 20 minutes. And if he stands up real quick or he gets up from sleeping, he has excruciating pain for 20 minutes. So he just doesn't sleep. He paces his house all night. And he has terrible PTSD. But he's a really dramatic guy. And he wants everyone to know how damaged he is, how terrible things are. So how do you figure that out? What's due to what? With Frank in the Flint water crisis, how do you know the kid wasn't dyslexic and maybe had some autism? How do you know that's due to toxic medical exposure? Similarly with Bob the boxer, the police officer. Like, how do you tease this apart? This is real through testing. It's time for testing. When you get cases that have complexity, that have different things going on, we have to look at this. So how does a neuropsychologist do that? What is our process? It's important that you understand how we look at things, how we document them, and what's a good product and what's not. So the assessment is broken down into several sections. First is a clinical evaluation, and that's an interview. That's where we sit down and we're working with someone, talking about their history, and we really try to have a collateral, meaning that we're going to talk to somebody else in their life that helps us verify the things that are going on. And we use that to understand what's going on neurologically, what's psychiatric, what's happening. We do a neurobehavioral evaluation. Now, that is looking at different neurologic symptoms behaviorally. It's the same thing as like a functional neurologic exam. And so, examples of that would be problems with like how you walk or your balance or muscle tone, if there's stuttering, word finding problems. What are you seeing? Now, it's important in cases. Number one, does it pass the sniff test? Number two, number two, does all this add up? What do I mean by that? Does your test data match what you see versus what's being reported? I'll bring up another great example. So I was in court not that long ago with a woman regarding a woman. She was rear-ended by someone going about 70 miles an hour. Had a small subarachnoid hemorrhage, and she goes on and on and on and on and on about how terrible her memory loss is. She can't remember anything, right? Nothing. That's what she says. But the neuropsych data, her memory was great. I mean, it was in like the top 20%. How do you explain that? Help us understand, right? Dr. Hertza, she's complaining about her memory. Her memory's fine. Because her memory's fine, does that mean that she doesn't have a brain injury? She's fine. Doesn't it mean she's lying? The example I gave was of my 14-year-old. So my 14-year-old does not have brain damage, right? He's actually a gifted, really smart guy. Now, does he forget when his tests are and assignments are? Absolutely, right? Did he totally forget a spelling test, vocab test about a month ago and did terrible? Absolutely. Does he have brain damage? No. So when our attention's impaired, when our processing's impaired, when our thoughts aren't well organized, when we have ADHD, it can impact and cause variable memory without the fact that there's not damage to those areas. So now we understand she experiences problems with memory, even though those structures are intact. We do standardized testing to help understand these type of different things. And we'll talk about that here in just a minute. So the process is over. You make a referral, you call Neuropsych Centers, you call um, all things neuro, and you let us know, hey, we need your help. Please send us medical records. We have no idea what we don't have. Example, last week I was on the phone with the lawyer regarding the case I had yesterday in court. And he said, Dr. Hertza, what do you need? I said, I need the 5 or more medical records prior to the injury. I said, why? We don't have that yet. So, well, I want to know what the mental status was. I want to know what the medications were. I want to know how she was doing before because she did have a car accident at age 17 that had a type of concussion. She did have a speech delay before. She did have COVID. So I want to know, and she had postpartum depression, generalized anxiety, and some obsessive compulsive tendencies. So I got the records. You know what the record showed? Mental status was stable. It showed that, yes, she had a history of postpartum depression, but her nurse practitioner stated in particular she no longer needs medications. 5 notes beforehand showed she was completely stable despite her history. So now we start to show what was going on before, what's going on now. So again, the records help us. And the other thing that comes up for any of you that have been in court or done depositions, they always ask you and they hold up a document, did you review this? You're like, nope. Did you review this? Nope. So we won't know what we don't have. We do our clinical interview, our neurobehavioral status exam. We give our testing, which runs roughly 4 hours. And that can be done either through telehealth or in person. The research does support high accuracy in telehealth, and this has been used, frankly, countless and countless times in court and is well supported. So don't be discouraged from the telehealth. You do need to do it in a computer. We have patients all the time that are trying to do it like in their car while talking to their girlfriend on their cell phone. Something tells me that's not valid. So, certainly we need to have the right setting in order to control for things, but it can be done telehealth or in person. Then we score it all, compare it against a normative sample, and integrate this into a report. And sometimes, frankly, my preference is to do this, is to sit with your patient and help them understand what the data supported and what the treatment plan is that you're writing. Now, neuropsychological evaluations, what can we do? We can help understand the underlying factors that contribute. And anybody can send this to us. I get referrals from MDs, PhDs, master's level, speech therapists, neurology, psychiatry, pediatricians. Case managers, lawyers, funding companies. It comes to me from everywhere. And when I'm asked, where do you get your referrals? Everywhere you could think of. And you could do really ages 2 on up. Now, one thing to understand about the very young children is sometimes the formal testing doesn't work as well because the brain is so variable during that age, but you still can compare their development against what we traditionally see. Example would be walking and talking 1 to 2, potty trained 3 to 4, latest 6 to 7, right? And you can compare that and understand. I had a case, and I think this is an interesting one. A very young girl was riding her little tricycle and got ran over by a dump truck in front of her house. Absolutely terrible, right? Before the injury, she was very social and she was engaged and she had lots of friends and at the time of her life. After the injury, which did result in a brain bleed, she ended up in the hospital. She did some type of rehab. She was conversing. She seemed to do okay, right? But then she started to get worse. She started to have more and more symptoms and she wasn't speaking, and eventually she went mute, completely stopped speaking, regressed in her abilities, was no longer reading. Okay. So neurosurgery said she's stable, she's fine. I don't understand how this is happening, right? I don't know. So ultimately, I'm brought in to help understand kind of where are we here. And the case is complicated because the mother that's involved is very invested in the child's symptoms. And sometimes that can be difficult to kind of tease apart in terms of what's happening. When we really did a deep dive, what we found on the neuroimaging is some softening of the brain secondary to her injury, which is why things got worse. So in this case, went from something where it was frankly discounted. I think the offer on the table was like $1 million. This kid's her whole life trajectory has changed. And after our assessment, now this is a $20 million case where this child can have support for the rest of her life. Because now she's like 8 years old, not reading, not talking. So now there's support for her. When I did the Flint water crisis, the courts asked us to try to determine and understand, do patients have the neurocognitive profile consistent with what you see from toxic metal poisoning? And do we have labs that line up with the fact that they were exposed? If both those things are the case, then those families were awarded $250,000. And we assessed about 180 children over 2 weeks. I had a team that flew to Michigan to do that. And the idea, again, is to understand, how does this affect people? What does it really show? So the purpose: diagnosis, patient care, quantification of symptoms, help understand severity level. And so we can establish a baseline, we could document functional limitations, differential diagnosis, write education plans to assess whether someone can drive, can they return to work, are they competent? And then, of course, for any type of forensic purposes that we've talked about. Things like changes in personality, changes in memory, communication, language, attention, all these things are assessed. So it could be concussion, stroke, ADHD, epilepsy, traumatic brain injury, PTSD, emotional regulation, tumors, pain, medical malpractice, anything that affects from here on up. That's our world. That's what we're experts in. Now, for forensics, whether it's civil or criminal, or it's more of an IME, and IME being just an independent look at things, whether it's can somebody return to work with what type of like restrictions, or establishing a life care plan, what type of treatment do they need and why, all those things we evaluate. Now, here's some more specific referral information here that talks about things like Parkinson's, stroke, TBI, and so on. Um, and we can also predict kind of the future to a good amount of degree. So generally after mild traumatic brain injury, as an example, and stroke, you got about 2 years. About 2 years for that brain to recover. But the brain doesn't recover at that same speed during that 2 years. So you can have some predictability, even relatively early on. How is this going to end up? What type of deficits are they going to happen? In dementia, you could predict things, even to some degree, lifespan, but what's going to happen next? What kind of problems are they going to have? How is the family support? What type of treatment is needed? So again, please send us medical records. I think it's beyond critical. The more detailed you are in the referral question, the happier you're going to be, because then we answer your questions. Um, Important, and I'm going to flip back here real quick on this last sentence. It says many neurological and psychiatric disorders have been empirically shown to have specific patterns of dysfunction. So particularly look at that psychiatric. What does that mean? It means that psychiatric disorders, including PTSD, have specific changes in the brain and also have specific physiological changes. PTSD is brain damage. Studies show changes to the volume of the brain, the interconnections, the ventricles, and in particular, the short-term memory, right? Short-term memory centers. So we go back to concussion, mild traumatic brain injury. Now, let's say you're past that 10 days, you're 2 years out, you're still having problems. You have problems from that, and you have damage from that PTSD, right? Now, a crucial aspect of testing, again, is looking at what we see to help understand what's going on. And we're looking at motor, sensory, perceptual, memory, processing, executive function, language, and emotion. I'm putting this out there because the reports are often organized this way. Typically, you'll have like overall intellectual function, and then they'll talk about attention and executive functions, which is like, as this says, like your initiation, inhibition, planning. And then we'll go to language and processing speed, visual based, and then you'll tend to hit memory and then mood. Some people vary a little bit, but that's often how we think about our patients, right? What is their intelligence? Can they focus? Are their thoughts organized? Can they make decisions? How are their language skills? How are they perceiving things? And how are they remembering? And of course, what's going on emotionally? Um, all right, I'll flip through this. So actually, I want to go back real quick. When I give this lecture face to face, I pick the people that are sleeping in the audience and make them do things to really embarrass them. And it's really fun to do because everyone looks to the floor and makes no eye contact. And so anyway, but I want to give you some examples, some behavioral things that we do and some tests that we do to help understand what's going on. So for attention, we do a digit span, and that's where you have to repeat numbers serially forwards and then you have to repeat them backwards. So if I were to say to you 973, you'd have to repeat it 973. If I said 6495, then you'd have to repeat that backwards for your working memory. We look at how quickly you could generate your words and find your words, both phonetically and then categorically. We can look at how your brain organizes things by making you draw a clock with the hands and numbers so a child could read it. The time is usually set to about 1:45, and look how you organize that. We can do a motor exam looking at motor planning, right? If you have problems with single alternating finger movements, it's dysdiadochokinesia. You can look at how the frontal lobe responds to things. Now, often we use a psychometrist. Psychometrist is typically a master's level provider that administers these tests, and they're trained in this. They go to school for this. So they're for a PhD, for a neuropsychologist, they're our extender. They're people that help us do this. Now, I do want to hit on, and I get to this a little bit later, some of the stuff that's coming out there with computerized testing that's only computerized. If you don't understand psychometrics, you are setting yourself up for a huge problem in court. Because frankly, some of these are like Facebook quizzes, right? You can get a Facebook quiz and you could try to figure out your IQ. And is that accurate? Of course not. It's a Facebook quiz. And so the neuropsychological testing, the process that we've talked about, all the details, the expertise, the time that's spent. When it's done computerized, you don't know what you're getting. I'll give you a great example. There are two major, three, but two major ones that are used nationally. I'm not going to name them, but one of which I started using for about 6 months and then stopped because the testing would show patients as super impaired at a level that didn't match at all how they presented to me at all. I just had an hour-long conversation with them, but according to with that was fluid and engaged, and according to the test data, they're in the bottom 2%. Doesn't pass the smell test. Something's funky. And then there's another one I used, and that one I find to be a little more accurate. But guess what? The normative sample, who everyone's being compared against, is the UK. It's not Americans, right? And so you can't take that data and make assumptions from it. All they are is screenings, right? And incredibly useful. You give one of these tests, listen, a neurologist, a chiropractor, anybody, give one of these screenings, have a neuropsychologist who knows what they're doing, say, okay, this is valid. And then that tells you I need a comprehensive eval. I know that there's likely a problem, so now I need to investigate why, how, what does it mean? What does it mean for my case? So again, not all testing is the same. And unless you're an expert in this stuff and you feel like you could defend psychometrics and normative samples in court, which I had to do yesterday, right? I'd be really cautious to do this yourself. So I'll give you an example. So um, I was asked about the somatization scale on the PAI, the Personality Assessment Inventory, and it was high in the 80s. It's very, very high. Okay, even over 60, you should be kind of, but this is in the 80s. And so the neuropsychologist, the doctor on the other side, actually is a local neurologist, said, well, they have somatization disorder. They have somatization disorder. That's what's happening. They have no brain injury at all. All this is due to emotional distress. I rest my case. Done. So I was asked about that. I said, Dr. Hertza, the SOM scale was like 82. Why didn't you diagnose a somatoform disorder? Do you not know the DSM? And I responded and I told her, I said, well, the personality assessment inventory is actually normed on everyday people. The MMPI is normed on psychiatric samples. So we're comparing our patient, our client, against normal people. Normal people haven't been in terrible car accidents. Normal people don't have lots of pain. Normal people don't have 7 discs, right, that are protruding. Normal people actually sleep. So the test is going to inflate the somatization scale because of how it's designed, because of how it's normed. I said, so that's why I didn't diagnose somatoform disorder, because the patient doesn't have it. And I got a hug from the lawyer at the end of the case. But it's understanding those things. Now, tests are standardized. They look at age, education level, ethnicity. And so we're comparing people against similar people. And the domains
Dr.
we look at
Hertza,
as, yes, ma'am.
we are close to the end. We have about 2 more minutes, and then I want to be able to get at least one question in. So I know that you have a lot more to, but maybe skip to
Sure, no
the
problem.
final, just so we stay within the time frame. Thanks.
Yes, ma'am. So some of the tests that we use that look at different domains are listed, and you can see those here, and they're looking at the different things we talked about, such as the ways, the R bands, and so on. It's important that you understand premorbid functioning, and so that is where we are estimating where somebody was at before their injury, like with that nurse practitioner. And so we are able to compare people against themselves, and that allows for incredible accuracy. Here's some examples of validity measures that we use and some of the personality measures. And this is just for your reference so you can see the different things. So yes, all these tests test the brain and different parts of the brain. We are functionally mapping how the brain is working, looking at attention, executive, vision, perception, and so on. So here are examples of tests and subtests and the different things they look at so that you could use this in court and understand what's going on. Understand that not all tests are the same, right? As a kind of a take-home message that they are screenings at best, that the validity stuff really matters. And you're looking at consistency across the different validity scores. And then everything is integrated. They're pulled together into one report that really helps understand what's going on. And then we give examples. So in pulling it all together, running through our cases, you could see with Betty, with Cindy and Sean, each one of these cases really needed someone to take time and understand what was going on. And by doing so, it highlighted the deficits that they were struggling with and allowed the case to be supportive. All right, Jen. So I'm gonna stop now and I'm gonna open for questions. Hopefully that was informative and helpful for everybody.
Yes, if you have any questions, we've got a couple more minutes. Definitely want to make sure you have a chance to ask any pressing ones that you have.
Experiences, snide remarks, we don't care. I hear crickets. It was so good. Everyone knows everything. They're all
That's how it
experts.
goes.
That's right. If you need us for anything, please reach out. Ultimately, our job is to help understand what's real and what's not, and provide evidence-based treatment, monitor its progress, and communicate with you as to what's happening and what to do about it.
Absolutely. So as we wrap up here, a couple things. Make sure I've got the right slide. I'm just want to mention, can y'all see that? Dr. Hertz, did you see this, my screen?
I do.
Okay, great. So really excited that this fall we're going to be launching our inaugural Southeast Neurotrauma Conference, October 24th through 26th at the Omni Hotel. We're going to be sending out some materials to get people once we have everything open. We're looking for sponsors and vendors. And if you know any attorneys or medical providers that would like to learn more about it, we would definitely love to have you all join us in the fall. So you'll be hearing more about that. But I'm really excited about this coming to the Southeast and being to provide lots of different types of speakers. Obviously, Dr. Hertz is going to be there and help everyone learn and navigate it. So we would love to connect with you if we can help you in any way. This is my information as business development manager. I'm here to help field you into the right ways of getting involved with us. This is my email, my cell phone, and if you have referrals, this is the form that we use that you fill out to help us streamline scheduling. But just want to say thank you again for taking your time to be here today at our first webinar. And hopefully you gain some insights and some tools in your tool belt to be able to help notice symptoms and be able to properly get your clients or your patients the care that they need. So with that, I want to thank everyone for attending and have a wonderful day. Thanks, Dr. Hertza, for helping and lead us in this discussion. Bye, everyone.